I think over the past 2 decades, we could say that the rate of colorectal cancer in younger patients has almost doubled. And if we look 2 decades forward in the future, this may be the biggest cancer problem we have in our society, early onset colorectal cancer. It may be the biggest problem we have in cancer. The reason we're seeing more and more young patients with colorectal cancer, I think, is multifactorial and actually not easily explainable by any single theory or reason. I think a lot of it has to do with the toxins that we are experiencing every day, whether it's things in our diet, chemicals in our diet, or forever chemicals that we're finding almost everywhere, and the number of almost insults that each patient on a population level and on an individual level is experiencing in their lifetime. We also have to consider things like the standard American diet, which not only is meat heavy, red meat heavy, which we know from population-based studies is a factor, but also the standard American diet over the past 2 decades has really evolved to have a lot of processed sugars, or at least high sugar content. And as we see the standard American diet spreading across the world, almost in a cultural phenomenon, we're seeing the same things happen in other countries. The signs that you should be looking for, while they don't necessarily mean you have colorectal cancer, should be at least setting off some alarms in your head. A sudden change in your bowel habits. If you're quite regular and now you're very irregular. If you're a person that normally has normal bowel movements and they're rock hard, or the nature has changed, they're thinner, or you're seeing blood in your stools that everyone else has told you is hemorrhoids. It's not hemorrhoids until you know it's hemorrhoids. I think a lot of the things that we brush off are the things that are really touch points for you to be able to tell your doctor about. For those people who have first-degree family members with colorectal cancer, and when we say first-degree family members, we mean mother, father, sister, brother, or children, the time to seek out screening for colorectal cancer is different than the rest of society. You should be seeking out earlier screening, which is usually colonoscopy. There aren't many other accepted forms of screening for colorectal cancer in this particular group of people. The age that we usually say you should be seeking out colonoscopy would be 10 years earlier than the family member who presented with the colon cancer. Now, if this is a much older relative, let's say age 75, first-degree relative, the rule goes to 40. So no later than 40, but 10 years prior to the presentation of that family member, no later than age 40. We have a rapidly evolving group of young patients that are developing cancers, and they have very specific needs that may be a little bit different than older patients. Number one, these patients that present under 50, they have very different challenges in their lives. Many of them are taking care of older relatives. Many of them have young children. Many of them have jobs that don't afford them the same freedom as older patients do. Many of them want to have children and are at that age where they are caught in the midst of a new diagnosis that may or may not involve surgery, may or may not involve chemotherapy, that may affect their ability to reproduce. And because we have a set of patients that really are caught in this sort of maelstrom or storm of differing needs and pressures, I think our center has really evolved to serve them as best as we know how to at Hopkins, and actually calling on all of our resources to really give them this blanket that we could wrap around them and help them through this difficult time. The specialists that you will see from the beginning will be, of course, most probably a surgeon, most probably a medical oncologist, and maybe even a radiation oncologist. Those people will be actively guiding your care, and they are a critical part of your care. However, I think people underestimate the other needs that younger patients with colon cancer have. There are stresses on their nutrition. Treatment has many downstream effects on reproductive health and nutrition. And many of the other services are very critical in the well-being of somebody who's starting this journey through cancer. We have dietary and nutritional support services. It is very easy to think of your nutrition and your health, your muscle mass, as being secondary to getting to your treatments. And some of these treatments have downstream effects where you don't necessarily feel like looking after your diet, or you're losing muscle mass and you don't know how to appropriately accommodate that. We have trained specialists here that are going to take you through this journey through nutritional supplementation to thinking about your health overall. And we are engaged very actively with our obstetrics and gynecology services for things such as doing egg banking, hormonal replacement, for procedures where special consideration has to be something that you think about for reproduction, in terms of suspending the ovaries or uterus out of the field of treatment. I think those are things that are not really actively thought about in patients at the time, because they're overwhelmed by the task at hand. And we will navigate you through this as a partner in your care. We do sperm banking, hormonal replacement. We can treat sexual dysfunction if it becomes an issue. Geneticists, researchers. I think people underestimate that at a research institution, we are poised and in a very good position to use the data that we've accumulated from patients just like yourselves, where we can use that data for you, and your data will actually be very useful to someone in the future. So we are building solutions for colorectal cancer with you, in partnership with you, and many times because of you.